Welcome to the deep dive. Today, we are immersing ourselves in one of the world's most widespread chronic respiratory diseases, asthma.
Mm-hmm.
We're going to go beyond the basics, taking a really detailed look at the cutting-edge pharmaceutical agents, dissecting the precise steps of international management guidelines, specifically GINA's 2025, and confronting that critical and I think often overlooked challenge of adherence and inhaler technique.
This is such an essential deep dive. I mean, we're tackling a condition that affects nearly 300 million people globally.
300 million, that's a staggering number.
It is. And while asthma is manageable, the variability in control is. It's huge. We have these powerful, effective treatments centered largely around inhaled corticosteroids or ICS, but the source material is just crystal clear. Variability in patient care and compliance means too many people remain at a severe and totally unnecessary risk.
That risk, that's the real narrative here, isn't it?
Yeah.
The sources really stress that asthma is absolutely a disease that can lead to death, and that risk is tragically amplified in low and middle-income countries.
Right.
So our mission today is to really unpack the entire system, moving away from just treating the immediate symptom, that scary acute attack, to understanding a proactive, really sophisticated strategy that's designed to minimize long-term harm.
It's a total paradigm shift. It really is. The modern approach, the stepwise management strategy, it recognizes that just providing a rescue inhaler is often, well, it's signing the patient up for a future catastrophe.
Future catastrophe.
Yeah. The treatment's goal now is twofold. It's about minimizing the day-to-day symptoms, which the guidelines call impairment, and equally minimizing that future catastrophic risk. And that means preventing exacerbations, preventing long-term lung function decline, and of course, reducing adverse effects from the medication itself.
That dual goal is so key.
Yeah.
Because you can feel okay day to day, but still be carrying this immense silent risk.
Yeah.
Okay, let's unpack this. And I think the best place to start is where all medicine begins. The tools. Before we talk about the strategy of when to use things, we need to know what they are and how they work. We're going to classify everything into two functional groups: rescue for the immediate crisis and maintenance for that long-term control.
That functional classification is everything. It really is. Rescue medications, they're designed for a rapid response. They need to work almost instantly, and their function is focused almost entirely on rapid bronchodilation.
Opening up the airways. Fast.
Fast. Maintenance medications, on the other hand, are slow-acting and preventative. They're focused overwhelmingly on anti-inflammation, which is, the root cause of chronic asthma.
Okay, so let's start with those immediate crisis intervention tools.
Sure.
The fastest hitters have to be the short-acting Beta-Agonists, or SABAs.
Yeah.
We're talking about salbutamol, which many of our listeners will know as albuterol.
Right, albuterol.
And terbutaline. These are the gold standard for acute relief.
They're absolutely the first line. They deliver that rapid bronchodilation, often working within just a few minutes, though their effect typically only lasts for about 4 hours. And the mechanism here is, well, it's a beautiful, intricate piece of cell biology. They specifically activate the G's protein-coupled beta adrenergic receptors, which are, abundant on the airway smooth muscle cells.
And the activation of that receptor kicks off a whole cascade, almost like a
Exactly, like a biological Rube Goldberg machine inside the cell.
Rube Goldberg machine, right?
Precisely. Once that SABA molecule hits the receptor, the G's protein complex signals an enzyme called adenyl cyclase. Adenyl cyclase then starts converting the cell's energy molecule, ATP, into cyclic AMP or CAMP. And you can think of CAMP as the critical second messenger in this whole process.
And what does that CAMP actually do to relax the muscle?
The rising concentration of stack MP activates something called protein kinase A. This kinase then acts on a bunch of downstream targets, but the critical effect for asthma relief is that it results in a dramatic decrease in the intracellular calcium level within that smooth muscle cell.
Calcium.
Right. Since muscle contraction, whether it's skeletal or smooth, is so heavily dependent on calcium, lowering that calcium level causes a smooth muscle to relax. And that gives you that rapid opening of the airways bronchodilation.
So if I'm following this, SABA is essentially putting a massive chemical stop sign on the cell's natural constriction process by flooding it with SAC-MP, which ultimately leads to relaxation. That's powerful, and it's fast, but that speed often comes with systemic spillover effects, doesn't it?
It does. I mean, because Bel-2 receptors are present not just in the lungs, but also in other organs like the heart and skeletal muscle, the common side effects are things like tremors, especially noticeable in the hands, palpitations or rapid heart rate, and headaches. The severity of these really depends on the exact dose and how it's administered.
This molecular mechanism actually connects directly to the biggest risk we talked about right at the top, SABA overuse. If the drug works by stimulating this receptor, doesn't chronic overuse eventually lead to a counterproductive effect?
That is the critical insight. It's exactly why GINA has pivoted so dramatically. Yes. Chronic, heavy reliance on SABAs can lead to what we call receptor downregulation or desensitization. The more you demand of those U2 receptors, the less sensitive they become over time.
So when you really need it.
Exactly. When a severe exacerbation hits and the patient truly needs that SABA to work effectively, their smooth muscles might be less responsive because of that prior overexposure. The SABA is providing rapid relief, sure, but it's simultaneously training the muscle to ignore it, all while doing absolutely nothing to treat the underlying inflammation.
That makes that SABA overuse risk statistic. That 3 or more canisters per year signals serious danger so much more profound. It's not just a statistical marker. It's a biological danger.
It's a physiological warning sign.
Okay, moving on to other rescue agents. We have the short-acting muscarinic antagonists, or SAMAs, like ipratropium. Where do they fit into an acute crisis?
So SAMAs are typically used as an adjunct therapy, so alongside SABAs, usually when the exacerbation is already moderate to severe. They're designed to layer on additional bronchodilation through a completely different pathway.
A different pathway. How?
So instead of stimulating the BIC2 receptors, they block the muscarinic receptors.
And why is blocking those receptors helpful in asthma?
Well, these receptors are normally activated by acetylcholine, which is a neurotransmitter that promotes what you call cholinergic bronchomotor tone. Basically, it's telling the airways to constrict. By competing with acetylcholine for these muscarinic receptors, SAMAs act as antagonists, so they inhibit that constrictive signal and promote further relaxation.
So they hit the same endpoint bronchodilation, but through a totally separate pathway, which I guess is useful when you need the maximum possible airway opening. But the sources note they aren't continued long-term into a hospital stay.
That's right. Their benefit is most pronounced during that initial acute crisis stabilization phase, often in the emergency department. Studies just haven't shown significant additional benefit for hospitalized patients once they're stabilized, so their use tends to be pretty restricted and tactical. Their side effects are usually limited to local discomfort, dry mouth, throat irritation, sometimes a bit of dizziness.
Okay, so when we cross that threshold into true moderate or severe exacerbations where inflammation and mucus are just overwhelming the system, that's when we need the heavy artillery. Systemic glucocorticoids, or GCs, given orally like prednisolone or intravenously like hydrocortisone.
GCs they're the necessary evil for refractory asthma. Their power lies in their mechanism. They are profoundly anti-inflammatory. They inhibit the synthesis and release of pretty much all inflammatory mediators, cytokines, chemokines, and they dramatically lower the infiltration and activity of key inflammatory cells.
But you mentioned a second mechanism that works synergistically with the bronchodilators we just talked about.
Oh, absolutely crucial. GCs are unique because they also increase the number and, more importantly, the sensitivity of the D2 adrenergic receptors on the smooth muscles. So not only are they reducing the inflammation that's causing the underlying problem, but they're also making the patient's own H2O agonists, whether they're from their body or from an inhaler, work much, much better.
That dual action explains why they are so effective at stopping a severe flare-up. But obviously, they carry the highest risk profile for long-term use.
Precisely. They are dose and duration dependent. Short courses are generally tolerated well, but prolonged or repeated use can lead to systemic problems like depressed immune function, which increases infection risk, and skeletal issues like osteoporosis. In very high doses or long-term repeated courses, we see a risk of Cushing's syndrome. They are lifesavers in the acute setting, but we absolutely have to transition patients off them as soon as possible.
And finally, for the truly life-threatening scenario, there's intravenous magnesium sulfate. What's the rationale for this last-ditch effort?
Magnesium sulfate is reserved for the worst-case scenarios, where conventional treatments haven't adequately restored airflow. Its action is simple. It's a potent, smooth muscle relaxant. It achieves this by reducing the influx of calcium ions into the airway smooth muscle cells, directly promoting relaxation and bronchodilation. It's similar in principle to how the SABA cascade reduces intracellular calcium, but it's acting via a different channel.
And the critical caveat here, of course, is patient safety due to potential electrolyte issues.
Yes. Clinicians have to confirm renal function before administration. Magnesium sulfate is strictly contraindicated in patients with renal insufficiency because of the risk of hypermagnesemia, which can lead to severe muscle weakness and cardiac issues. It's a powerful tool, but one you have to use very carefully.
That completes our pharmacological inventory for acute intervention. So if that's the acute fix, how do we pivot and prevent the crisis from happening in the first place?
Yeah.
This brings us to the maintenance medications. And the cornerstone, which you flagged right in the introduction, is the inhaled glucocorticoids, or ICS.
ICS agents, budesonide, fluticasone, are simply the most effective anti-inflammatory medicines available for long-term asthma control. They are the absolute foundation of all modern maintenance therapy. They reduce symptoms dramatically, they improve long-term lung function, and crucially, they slash the risk of severe exacerbations, hospitalizations, and death.
And the sources made a point that's often missed. The bulk of the clinical benefit is achieved at surprisingly low doses.
That's a key piece of information. It really is. Because of their potency, moving from a low dose to a high dose doesn't always give you a proportional increase in benefit, but it does carry a proportional increase in the risk of systemic side effects. So the focus is always on finding the minimum effective dose.
In persistent asthma, ICS agents are almost always paired with a long-acting beta-2 agonist, or LABA, such as formoterol or salmeterol. Why is this pairing so common?
Because it addresses both elements of asthma simultaneously. The inflammation with the ICS, and the bronchoconstriction with the LABA. LABAs provide sustained, smooth muscle relaxation with effects that last around 12 hours. It's that prolonged nature of the relaxation that makes them suitable for maintenance, rather than just for acute relief.
But here we circle back to a crucial safety point from the regulatory world. LABAs should never be used without an ICS in asthma patients.
That mandate is in place because if a patient relies on a LABA alone for maintenance, they are constantly treating the symptom of tightness without ever addressing the underlying inflammation. This masking effect can lead to catastrophic, sudden exacerbations because the underlying disease is silently getting worse.
So it feels good, but the fire's still burning underneath.
Exactly. And the combination is pharmacologically brilliant too because, as we mentioned earlier, the corticosteroid component actually increases the number and sensitivity of the bronchial LABA receptors, making the LABA work better than it would on its own. It's a mutual functional amplification.
So the combination offers sustained bronchodilation, amplified receptor sensitivity, and fundamental anti-inflammatory power. Considering patients are using these every single day, what are the primary side effect concerns?
Well, since we are inhaling the drug directly into the lungs, most of the side effects are local and manageable. The most common are dysphonia, which is just hoarseness, and oropharyngeal candidiasis, which is a localized yeast infection in the mouth and throat. A thrush.
In the simple fix for the candidiasis.
It's remarkably simple, and it must be emphasized to the patient. Rinsing the mouth with water and spitting it out immediately after using the ICS inhaler significantly reduces the local dose and prevents that candidiasis from developing. Systemic side effects like cataract formation, glaucoma, or osteoporosis only become a genuine concern with very high doses used over very long periods.
Okay, so beyond that foundation of ICS-LABA, we have alternative or add-on maintenance therapies. First, let's look at an older class, methylxanthines, or phosphodiesterase inhibitors, like theophylline.
Theophylline is fascinating because its mechanism is a bit of a double whammy. It works primarily by competitively inhibiting an enzyme called phosphodiesterase. This enzyme is responsible for breaking down CAMP, that critical signaling molecule we discussed earlier. By blocking the breakdown of CAMP, the levels remain high, leading to sustained, smooth muscle relaxation and bronchodilation.
And what about its anti-inflammatory mechanism?
It also has an anti-inflammatory component, which involves activating histone deacetylases. These enzymes inhibit the synthesis of pro-inflammatory factors in the cell, helping to quiet the chronic inflammation.
That sounds broadly useful, combining two key functions. So why isn't theophylline a standard routine maintenance therapy anymore?
The challenge is the pharmaceutical knife edge it walks. It has a very narrow therapeutic range. The dose that works is often perilously close to the dose that becomes toxic.
So it's hard to get it just right.
Very hard. It requires therapeutic drug monitoring, regular blood tests to make sure the drug levels are safe, which is costly and cumbersome. And when you combine that with adverse effects like severe nervousness, insomnia, GI disturbance, tremors, it just became too difficult to manage routinely compared to the excellent safety profile of inhaled therapies.
Okay, next we have the oral agents, the leukotriene receptor antagonists, or LTRAs, such as montelukast. How do these target inflammation differently?
LTRAs target a specific class of inflammatory mediators called leukotrienes. These are molecules released by various inflammatory cells that, when they bind to their receptors, trigger powerful downstream effects leading to bronchospasm, mucus secretion, and smooth muscle contraction. Montelukast simply blocks the leukotrienes from binding to these receptors.
So it's a selective blocker. It's useful in certain phenotypes, often combined with ICS-LABA or used as an alternative step 3 treatment. But this brings us to a crucial detail that absolutely requires clarity for the listener. The sources flag a severe caution with Montelukast.
This is a serious issue that demands attention. Montelukast has been formally associated with the risk of severe behavioral and mood changes, which can include agitation, aggression, and critically suicidal ideation. This is not a common side effect, but the gravity of the risk means it must be discussed openly with patients and caregivers. If a patient experiences any changes in mood or behavior, the drug must be stopped immediately. This caution really dictates how and when clinicians consider using LTRAs.
That insight dramatically shifts the risk calculation for the drug, placing a heavy emphasis on proactive mental health monitoring alongside physical control.
Absolutely.
Finally, let's discuss the newest, most specialized tools. The monoclonal antibodies, or MAs, reserved for severe asthma patients.
These are really the pinnacle of precision medicine in asthma. They're typically administered via subcutaneous injection, and they target very specific elements of the type 2 inflammatory pathway. Take omalizumab, for instance.
Omalizumab targets immunoglobulin E, or IgE.
Yes. IgE is the antibody that's often responsible for allergic reactions. Omalizumab binds to the free human IgE circulating in the blood. By reducing the overall IgE level, it prevents the subsequent release of potent inflammatory mediators from cells like mast cells and basophils. It essentially quiets the allergic trigger before it can cascade.
And then we have the agents that specifically target the eosinophil pathway, which are often used for patients with high eosinophil counts.
Right, these target interleukin-5 or its receptor. Mepolizumab, risalimumab, and benralizumab are the examples here. IL-5 is a cytokine that's essential for the growth, activation, and survival of eosinophils, which are key inflammatory cells in type 2 asthma. By blocking IL-5 signaling, you dramatically inhibit those inflammatory responses, often leading to a profound drop in eosinophil counts.
And dupilumab blocks a different set of interleukins IL-4 and IL-13.
Correct. Dupilumab blocks the shared receptor for IL-4 and IL-13, inhibiting their combined inflammatory activities. These are broad, powerful inflammatory drivers. And the newest agent, tezepelumab, binds to thymic stromal lymphopenen, or TSLP. And TSLP is an inflammatory cytokine that's released right at the top of the signaling cascade by the airway epithelial cells that have been stressed or damaged.
So tezepelumab is almost acting higher up the chain than the others, intercepting the inflammatory signal before it even gets fully translated.
Exactly. These MABs represent highly tailored step 5 therapy, and they require referral to specialists who can phenotypically assess which inflammatory pathway is dominant in that specific patient. It just confirms that asthma treatment is no longer a one-size-fits-all approach.
Okay, so we've established this incredibly deep bench of pharmacological tools. Now we move into the strategy of how to use them, the stepwise management philosophy. The core challenge, as you mentioned, is the variability of asthma. So how do the guidelines structure this assessment?
The entire system is built upon 3 concepts that help clinicians categorize where a patient stands: severity, control, and responsiveness. And we have to clearly distinguish these.
Let's nail down those distinctions.
Okay, so severity is the intrinsic intensity of the disease itself. It's what you would measure if the patient wasn't taking any controller therapy. It defines the initial required treatment step. Control, on the other hand, is the measurement of success. It's the degree to which your current therapy is minimizing symptoms and risks. And then responsiveness is the clinical measure of how easily control is achieved for that specific patient with a given therapy.
And when assessing control, the guidelines break it down into those 2 domains that must always be optimized: impairment and future risk.
Impairment is about the patient's day-to-day life. Frequency and intensity of current symptoms, their need for rescue SABA use, nighttime awakenings, ability to perform daily activities. Future risk, however, is arguably the more critical domain because it is silent. It involves the likelihood of severe exacerbations, progressive lung function decline over decades, or adverse medication effects.
This dual assessment is where the strategy becomes so complex, because simply managing impairment, making the patient feel fine day to day, doesn't guarantee they're safe from future risk.
That is the pivotal shift in modern asthma care. The most important metric in assessing future risk is SABA overuse, as we discussed. Again, if you are using 3 or more 200-dose SABA canisters a year, you are at major risk. 12 or more canisters a year is a statistically high risk for asthma-related death. That is a measurable, actionable warning sign that the current control strategy is failing catastrophically.
So, if the control strategy is failing, we must adjust. The concept of adjusting therapy is divided into three distinct contexts: step-up long-term, step-up short-term, and step-up intermittent. Let's start with SLT, the long-haul adjustment.
Step up long term is what's required when the lack of control is persistent, say for 2 to 3 weeks or longer. This means a permanent move up the guideline step ladder, for example, moving from step 2, step 3 maintenance therapy. This is where historical clinical trial data really shaped our current practices.
The early 2000s saw a major debate. Once a patient was on low-dose ICS, what was the better step 3 move, adding a LABA or simply doubling the ICS dose?
Right. And initially, studies like those by Greening and Woolcock focused mostly on impairment. They showed adding a LABA was superior to just doubling the ICS dose for many of those day-to-day symptom outcomes. The bronchodilation felt immediately effective to the patient.
But then the focus shifted from just feeling good to preventing catastrophe, which led to the landmark FACET study.
The FACET study helped reinforce that we needed to address future risk, those severe exacerbations. And the results were compelling. Patients on low-dose ICS who had a LABA added reduced their severe exacerbations by 26%. Simply quadrupling the ICS dose alone reduced exacerbations by 49%. But the combination of high-dose ICS and a LABA was the real winner, reducing severe exacerbations by a remarkable 63%.
Wow.
Yeah. This demonstrated that for robust risk reduction, the combination therapy was superior and it justified the increased pharmacological burden.
And then the GIL study, Gaining Optimal Asthma Control, provided the real-world evidence for the process of stepwise adjustment.
The GIL study looked at sustained control over a full year. It used a predefined stepwise escalation plan involving either fluticasone alone or the fluticasone-salmeterol combination. And it proved that this controlled stepwise process successfully helped patients, even those starting with severe symptoms, achieve and sustain guideline-defined control over time. It validated the entire premise of the stepwise method as a reliable, systematic approach to manage varying severity.
What stands out to me is the necessary recognition that not every patient will respond to the same step 3 treatment. The Badger trial looked at this in children.
The Badger trial involved children aged 6 to 17 who were uncontrolled on low-dose ICS, and it compared adding a LABA, adding an LTRA, montelukast, or increasing the ICS dose. And what they found was that the response was highly differential. While the LAB step-up showed the greatest likelihood of the overall best response, 98% of the children showed a superior response to one of the step 3 options over the others.
So it's not a generic step 3, it's a menu of options. And if one fails, you should try another step 3 option before just defaulting to step 4.
Exactly. It mandates monitoring and adaptability. We also see newer options becoming viable step 3 additions, such as the long-acting muscarinic antagonists or LAMAs like tiotropium.
Tiotropium was a long-term option for COPD for a long time, but how does it slot into asthma step-up long-term?
Well, studies, like those led by Peters, showed that adding tiotropium resulted in greater improvements in lung function and symptom scores compared to just doubling the ICS dose. Importantly, it was found to be non-inferior to adding salmeterol, a LABA, across all the outcomes they assessed. This solidifies adding a LAMA as the legitimate non-bronchodilator-based step 3 option, especially when patient adherence to a new LABAX combination might be questionable, or if the patient's phenotype suggests an alternative mechanism might be beneficial.
That concludes the strategy for persistent lack of control. Now let's discuss step-up short-term, or SST. This is for that brief, anticipated loss of control. The classic example being an impending viral respiratory infection or a known short-term exposure trigger.
SST is all about early prevention over 3 to 10 days, aiming to prevent a minor symptom flare from escalating into a full-blown exacerbation that requires oral steroids. For decades, the knee-jerk clinical reaction was to tell the patient, just double your maintenance ICS dose.
And the clinical trials provided a pretty harsh correction to that conventional wisdom.
They did. The Fitzgerald trial showed that simply doubling the ICS dose was largely ineffective in managing impending exacerbations. The dose just wasn't high enough, or the inflammation was already too far gone. However, the Alvern trial investigated quadrupling the dose.
And what were the key findings of that quadrupling strategy?
They found that quadrupling the ICS dose was effective in reducing the need for oral corticosteroid-requiring exacerbations, but they flagged 2 critical conditions that define success in SST. The patient had to be highly adherent to the protocol, and they had to start the increased dose immediately at the very first sign of symptom worsening. If they waited, the benefit was lost.
So it's fragile.
Exactly. This highlights the fragility of the SST strategy. It relies utterly on perfect patient adherence and timely response.
There was also an interesting intermittent SST strategy tested in mild persistent asthma, where the controller therapy was only used when symptoms flared up, essentially only for those 3 to 10 days.
Right. This approach was tested in the Bushi and Ames trials, often compared against daily low-dose ICS. They showed that an intermittent high-dose ICS regimen, used only when symptoms worsened, could be comparable to daily low-dose ICS for many primary outcomes in mild persistent asthma, especially in children with a positive modified asthma predictive index.
That finding suggests a surprising tolerance for intermittent high-dose steroids in the mildest cases.
It confirmed that for a specific population, mild, intermittent asthmatics, you might get away with using a much lower cumulative medication dose overall, provided the patient is vigilant about starting that higher dose immediately when a flare-up threatens. This leads us directly into the third and most innovative strategy, the step-up intermittent, or SUI, which focuses on day-to-day relief.
This SUI concept is the real game changer, because it merges the quick rescue mechanism with the long-term control mechanism.
Exactly. The concept is to use the controller medication itself, which must contain a rapid-acting bronchodilator, as the reliever medication for daily symptoms. The most successful implementation of this is maintenance and reliever therapy, or MART, which uses a combination of ICS and the rapid-acting SABA-Formoterol.
The genius here is formoterol's mechanism. It's a long-acting drug, but it also has a rapid onset of action, which makes it suitable for quick relief.
That combination is perfect. Every time the patient experiences a symptom, they take a dose of their controller, which gives them instant relief from the formoterol, and they get a critical dose of anti-inflammatory ICS.
The evidence for this must be overwhelming, given how logical it sounds.
It is. The STAY study, for example, demonstrated that the ICS-formoterol MART regimen resulted in a massive 45 to 47% lower risk of severe exacerbation compared to traditional fixed dosing regimens where SABA was used for relief. It achieves superior risk reduction, and crucially, it simplifies the patient's cognitive load down to one inhaler and one technique.
But you mentioned regulatory hurdles, particularly in the U.S., that initially slowed the adoption of this specific combination as a reliever.
That's right. Because of historical safety concerns related to using long-acting beta-agonists, the FDA dampened enthusiasm for the MART approach initially, even though it was used internationally. This prompted researchers to look at alternative SUI approaches that didn't rely on LABAs, which led to the Papi and Martinez trials focusing on combining ICS with SABA relief.
Let's unpack the Papi trial first, which focused on adults with mild asthma.
Okay, so the PAPI trial compared patients with mild asthma who were already controlled on daily ICS. They tested various arms, including one where patients only used a single inhaler combining low-dose beclomethasone, an ICS, and albuterol, a SABA, as needed for symptoms. This was the SUI strategy.
And what were the surprising results of this as-needed combination strategy?
The number of severe exacerbations in this as-needed combination therapy group was significantly lower than in the SABA-only group. What was truly remarkable and a massive win for the patient was that the patients in the SUI arm achieved this superior risk control while receiving a lower total cumulative dose of inhaled beclomethasone over the year compared to the groups that were taking daily maintenance ICS.
So they traded daily maintenance for intermittent relief, reduced their exacerbation risk, and cut their overall medication exposure. The Martinez trial then confirmed a similar benefit in children.
Yes, in children with mild persistent asthma, the SABA-only group had an exacerbation rate of almost 50%. The rescue icosabuterol group, the SUI group, reduced this risk significantly and was comparable to the daily ICS groups, but the children only received 15 to 25% of the cumulative daily ICS dose. This provided powerful evidence that combining an anti-inflammatory with the rescue inhaler, even if it's a SABA, is a valid and safer alternative to SABA-only relief in mild cases.
This wealth of evidence, from the FAST study proving risk reduction with combination therapy to the SUI trials demonstrating the power of intermittent anti-inflammatory relief, this all leads us directly to the solid strategic shift embodied by the GINA 2025 guidelines.
GINA 2025 makes an unequivocal, absolute mandate. All adults, adolescents, and children over 6 must receive ICS-containing treatment. The use of as-needed SABA alone for asthma treatment is now actively discouraged because it increases the risk of exacerbations and death. This is the official end of SABA-only treatment for virtually everyone.
And this commitment to anti-inflammatory relief is operationalized through GINA's 2 tracks. Track 1, the preferred approach, and Track 2, the alternative.
Track 1 is the gold standard. Anti-inflammatory reliever, or AR therapy. The medication of choice here is low-dose ICS-formoterol used as the reliever. It is preferred because it leverages that strong evidence showing it significantly reduces the risk of severe exacerbations compared with any SABA reliever regimen.
And the simplicity factor must be a huge driver of its preference, especially when we start considering adherence later on.
Oh, absolutely. It simplifies the patient's life down to one device, one technique, which serves two purposes. If we look at the steps for adults and adolescents in track 1, steps 1 and 2, which are for infrequent symptoms, the patient takes low-dose ICS-formoterol as needed. That's AR only. They don't take a daily maintenance dose unless their symptoms increase.
Okay.
Then for steps 3 and 4, for more frequent symptoms, the patient moves to low or medium-dose ICS-formoterol for maintenance and continues to use it as needed for relief. That's the full MART strategy.
So whether your symptoms are mild and infrequent at step 1 or they're constant at step 4, you are getting anti-inflammatory protection alongside bronchodilation, and you only need to master one device. It's elegant.
It is.
What about track 2, the alternative? Why would a patient or clinician choose that?
Track 2 is the traditional structure. Daily maintenance ICS-containing medication plus a SABA, or ICS-SABA, as needed for relief. GINA designates this as an alternative only when track 1, the ICS-formoterol, is unavailable, or for a very stable, highly adherent patient who explicitly prefers a fixed daily dose regimen. However, clinicians must actively inform the patient that track 1 provides a superior reduction in severe exacerbation risk.
Let's talk about how a clinician decides where to start a patient on this map.
Here.
Initial treatment is based entirely on defining the patient's current severity.
That's right. If the patient presents with infrequent symptoms less than 4 to 5 days a week, they are placed at initial steps 1-2. The guidance is to immediately initiate track 1, low-dose ICS-formoterol as needed, AR only. There is no SABA-only option anymore.
And if the patient presents with more frequent symptoms most days or waking weekly or more due to asthma, they skip steps 1 and 2 and move immediately to a daily maintenance strategy.
Exactly. They move immediately to step 3 or 4, initiating daily maintenance therapy, ideally the MART strategy from track 1. If a patient is presenting with severe symptoms, they may even start at step 4 or 5 and require immediate specialist referral. The philosophy is treat to control symptoms and risk, then assess.
This systematic approach needs an exit ramp once control is achieved, which is the stepping down process.
Stepping down is crucial for 2 reasons: minimizing the long-term risk of systemic side effects from the ICS, and confirming the minimal effective dose required to maintain control. Stepping down can be considered when asthma has been well controlled for at least 3 months. The ICS dose should then be reduced incrementally, usually by 25 to 50% at a time, followed by a reassessment period.
There was that debate concerning the stepping down process. If a patient is well controlled on an ICS-LABA combination, should the LABA be withdrawn first?
Right. That debate was driven largely by regulatory caution in the U.S. context. However, multiple clinical studies looked at this and found that when patients who were well controlled on ICS-LABA had the LABA component withdrawn, their asthma control became significantly less reliable. In some cases, lung function dropped, exacerbation risk increased. So current clinical data does not support withdrawing the LABA component first when stepping down. It is generally safer to try reducing the ICS dose incrementally while keeping the combination intact.
We have dissected the chemical tools and the complex data-driven strategy. But the source material reserves a dedicated and critical section for the point where all of this planning can just fall apart: the human element. The best drug with the best strategy is completely useless if the medicine doesn't actually reach the lungs.
This is the real-world gap between evidence and outcomes. Poor inhaler technique is, without any hyperbole, an epidemic. The statistics are horrifying. Numerous studies show that 90% of patients make errors overall in using their inhalers. One specific study highlighted that 61% of patients got their pressurized metered dose inhaler, or PMDI, technique wrong even after 3 dedicated attempts at instruction.
And 61% after 3 tries. The scale of this failure is immense. Why should the learner care about this technical detail? What is the clinical translation of a poor technique?
The clinical outcome is dramatic and expensive. The source material shows that making 1 or more critical errors in inhaler technique is associated with a 50% increase in the need for a systemic corticosteroid course, hospital admission, or an emergency department visit. I mean, think about that. A simple mistake in how you breathe in directly translates to a 50% higher chance of being in the hospital.
That is a direct cause and effect. Poor technique means inadequate drug delivery, which leads to undertreatment. The patient then assumes the drug isn't working, so they stop adhering to the controller and they rely only on SABA rescue, and that just fuels the cycle of increased risk.
It creates a vicious cycle of therapeutic nihilism. And the factors associated with this high error rate: age, limited educational background, but most importantly, a lack of consistent personalized training. And crucially, prescribing multiple different types of devices for one patient. If one device requires a fast, forceful suck and the other requires a slow, gentle puff, the chances of confusion just skyrocket.
And what makes this cycle even harder to break is the provider gap.
Yes. If we are honest, few healthcare professionals can demonstrate the correct use of all the different types of inhalers themselves. If the person training the patient doesn't know the 4 or 5 critical steps required for a specific device, the patient is set up for failure before they even leave the clinic.
So GINA provides a structured solution to this, recognizing that checking technique must happen before automatically stepping up the medication dose. Walk us through GINA's 4-step solution.
Okay, step 1. Choose the most suitable device for the patient. You have to consider their physical ability, their age, their cognitive ability. If a patient has arthritis, they may not be able to load a DPI. Step 2. Check technique at every single opportunity, at every visit, at every refill. Step 3. Use an effective mode of training. Physical, hands-on demonstration and the teach-back method, where the patient shows you how they do it, is far superior to just handing out written instructions.
And step 4.
Inhaler skills training must be repeated routinely, both for patients and for the healthcare professionals responsible for training.
Let's look at some of the specific critical errors, starting with the classic meter dose inhalers, or MDIs, the pressurized cans.
For an MDI used without a spacer, the most classic error is that lack of coordination, what we call the hand-lung coordination gap. The patient either actuates the dose too early, before they start inhaling, or too late, after they've finished inhaling. This means the drug just hits the back of the throat instead of traveling deep into the airways. Other errors include failing to hold the inhaler upright or inhaling too fast, which defeats the purpose of the slow spray.
And when a spacer is added to the MDI, the technique changes slightly, and so do the common errors.
The spacer simplifies coordination, but it introduces new critical errors. The patient has to create a tight seal of their lips around the mouthpiece, and they have to only actuate one dose at a time into the chamber. The absolute most critical error, though, is failing to inhale through the mouthpiece within 2 seconds of discharge. The aerosol suspension in that spacer is only stable for a moment. If they wait too long, the medication falls out of suspension and just settles on the spacer walls.
Contrast that with the technique required for dry powder inhalers, or DPIs, like the Discus or Turbohaler. These require a completely different breathing pattern.
DPIs rely entirely on the patient's own inspiratory flow rate to break up the dry powder and deliver it. You need a fast, hard suck. The critical errors here are the absolute opposite of the MDI. The number one failure point is blowing into the device before inhalation, which can destroy the dose delivery mechanism or scatter the powder. Second is inhalation through the nose instead of the mouth. And third, the patient's inhalation not being forceful enough from the start. For the turbohaler specifically, the patient needs to generate a very high, instantaneous inspiratory flow, a very fast suck, to generate the necessary turbulence to ensure adequate drug dispersal.
This complexity is why that single inhaler system of GINA 1 is so powerful. It drastically reduces the likelihood of these devastating technical errors.
The simplicity is not a secondary benefit. It is a primary driver of risk reduction. Fewer devices mean fewer techniques to master and fewer chances to make a critical, hospital-inducing error. This constant management brings us back to the structure of care, the assess, adjust, review cycle.
Right, this cycle emphasizes that asthma is never a fixed treatment plan. It is continuous.
Asthma care has to be continuous and cyclical. After starting or changing treatment, the patient must be systematically reassessed for symptoms, side effects, lung function, and their satisfaction with the regimen. Review should occur 1 to 3 months after starting treatment and then routinely every 3 to 12 months thereafter for stable patients. If there's an exacerbation, review is mandatory within 1 week to understand what failed.
And despite all the strategies and the technological advances, poor adherence to the daily ICS regimen remains the massive stumbling block.
It's the elephant in the room. When adherence fails, the patient defaults to SABA-only use, and the risk of severe exacerbation and death skyrockets. Strategies to improve adherence are low-tech and high-impact. Shared decision-making, where the patient is involved in choosing the most convenient treatment, clear education on the why not, just the how in utilizing technology like electronic reminders or even home visits by asthma nurses.
Finally, we should briefly touch on specific patient populations and comorbidities that complicate control, because treating the asthma alone often isn't enough.
That's a critical point.
Yeah.
Several comorbidities significantly worsen asthma control. Obesity is a huge factor because it increases inflammation systemically, and it puts mechanical pressure on the airways. The good news is that weight reduction, even a modest 5 to 10% loss, can lead to clinically significant improvements in asthma control.
And allergic rhinitis or chronic rhinosinusitis, common conditions, must be actively managed if we want the asthma to improve.
They absolutely have to be treated, typically with intranasal corticosteroids. The inflammation in the nose and sinuses is connected to the inflammation in the lower airways. If you leave the upper airway inflammation untreated, it will chronically complicate and worsen asthma control.
And for pregnant women, the instruction is clear. Continue the ICS.
Yes. The risks associated with an uncontrolled asthma exacerbation during pregnancy, including preterm delivery, low birth weight, and increased perinatal mortality, are far greater than the negligible risks posed by continuing the ICS-containing treatment. Monitoring should be meticulous and occur every 4 to 6 weeks during pregnancy to ensure control is maintained. You're treating the underlying inflammation to protect 2 lives, not just 1.
So we've taken the full deep dive today. We started with the molecular matrix of the drugs, distinguishing the lightning-fast mechanism of SABA rescue from the anti-inflammatory core of ICS maintenance. We analyzed the strategic evolution, showing how landmark trials shifted guidance away from treating symptoms toward eliminating catastrophic risk, culminating in GINA's preference for the single inhaler anti-inflammatory reliever, Track 1.
And the synthesis for you, the learner, is this. Asthma control isn't a passive state achieved by a single prescription. It's an active, cyclical process of managing complexity. The most sophisticated, expensive biologic drug can be rendered inert by a single, tiny error in inhalation technique. The gap between treatment guidelines and successful real-world outcomes is almost entirely dependent on successfully mastering that variability, ensuring adherence, and having a clear, actionable plan.
It's incredible to think that all that sophisticated pharmaceutical engineering hinges on perfect hand-lung coordination. Before we wrap up, let's revisit that careful balance of risk embedded in these guidelines. We know SABA alone is a high-risk gamble, yet it's simple and it provides instant relief. We also know that the alternative LTRAs, like montelukast, carry the rare but very serious adverse mental health risks.
That tension presents a complex trade-off for clinicians and for policymakers.
Exactly. So given the gravity of the montelukast safety profile and the universal danger of SABA-only reliance, should the international guidelines prioritize finding ways to reduce the complexity or cost of simpler anti-inflammatory reliever regimens, like the ICS plus SABA-SUI approach used in the Papi and Martinez trials, making that hybrid approach the absolute go-to for steps 1 and 2 globally? This could immediately introduce anti-inflammatory relief to the mildest patients, mitigating the SABA-only high-risk gamble without relying on drugs with serious mental health cautions. What stands out to you about how risk is balanced in these constantly evolving strategies? Think about that tension between simplicity, systemic safety, and reducing catastrophic risk as you process this deep dive.